Greeting to all the Physiotv viewers. We once again welcome you for the next another session for CPR and musculoskeletal rehabilitation. And for this, we will cover today with the part 2. I hand over the session to Dr. Sibi sir for the very informative talk. Over to you, sir.
Next, coming to clinical prediction rule application in musculoskeletal practice. So how can you apply CPRs into your musculoskeletal practice? It is the interpretation that there is potential value in the use of CPRs in musculoskeletal clinical practice. However, that value is presently limited to well-developed diagnostic and prognostic forms of CPRs. Diagnostic and prognostic CPRs have fewer assumptions related to their prescriptive counterparts, and in the case of diagnostic CPRs, they have more definitive outcomes. Although prognostic CPRs use outcomes similar to those of prescriptive CPRs, these tools look primarily at baseline measures and their relationships with general outcome findings. Prognostic CPRs do not require the determination of outcomes based on a treatment provided, as prescriptive CPRs assume. So we feel that diagnostic CPRs can provide value in clinical decision making by helping clinicians reason through a potential underlying element supplying the diagnosis. So diagnostic CPRs will use an outcome variable of disease, thus improving the likelihood of discriminating the given situation at hand. Diagnostic CPRs are developed by combining clinical findings that are the closest component to a reference standard, and in some cases, they actually make up the reference standard. Prescriptive CPRs suffer from many challenges that may actually erode the clinical reasoning processes used by clinicians. So by their nature, prescriptive CPRs assume the validity of an outcome value, assume that the treatment interventions have distinguishing effects. They assume that the treatment effects are strong enough to distinguish from the given prognostic influence of the baseline characteristics of the patient. These are lofty assumptions that, to date, have not been verified in most mechanically oriented musculoskeletal conditions. So consequently, for musculoskeletal clinical practice, we support the use of well-developed prognostic and diagnostic CPRs, but do not support the use of nearly all musculoskeletal-based prescriptive CPRs derived to date. So in musculoskeletal rehabilitation, we understand that as of today, we can make use of CPRs to diagnose a patient and to decide the prognosis of a particular patient, but prescriptive CPRs are not very much used because the development stage has not reached uh, the level 1 and 2. Regardless of your strategy for using CPRs, we advocate for the use of clinical reasoning as a trump card over any CPR presently available. For multiple reasons, CPRs will not always be available for the particular clinical decisions at hand or be appropriate for all categories of clinical judgment. So even though you have CPRs for few conditions, you may not have CPRs for every condition. So at the end of the day, along with CPR, you need to use your clinical decision-making skills, which will come with your experience, uh, to make informed decisions. Statistical modeling methods such as CPRs assist in informing clinical reasoning, not replacing it. So it is just going to assist you, but clinical reasoning will be the foundation always. CPR should not be used in isolation while making decisions, but rather as one component of the larger clinical decision-making process. We believe that when considered within the larger context of evidence-based practice, prediction rules can be very helpful in uncovering associations that unstructured clinical observations might otherwise miss. So clinical observation is very subjective, as I told you, and it is very unstructured. The advantage of the CPR is that it is very structured, it is very rigid, and there is no human cognitive biases. So we therefore recommend that One considers these CPRs along with the current existing evidence, patient preferences, and clinical experience when reaching clinical decisions. So, whenever you make any clinical decisions, it has to be a CPR along with consisting the existing evidence, along with patient preferences, because we have more of patient-centric approach these days, and obviously the experience of the therapist also equally matters. So when used in this manner, CPRs strengthen clinical decision making, but not to forget your clinical experience, patient preferences, and the existing evidence. So it is important to remember that CPRs are not a substitute for decision making. Rather, they are tools to help guide the decision making process, whether diagnostic, prognostic, or intervention. So it is just a guide, but it can never be a substitute for decision making. By combining experience, patient's value, and the best current evidence, which includes prediction rules, clinicians can make informed decisions as to the most effective and efficient way care for their patients. It is a physiotherapist's responsibility to recognize conditions that may require a medical examination because we have our own limitation. So this tool will help screen for conditions beyond the scope of physical therapy treatment and require referral to another medical practitioner. So the screening tools available currently are the Ottawa Foot and Ankle Rules, Ottawa Knee Rules, Pittsburgh Knee Rules, Canadian Cervical Spine Rules, the Osteoporosis Risk Assessment Index Instrument, Simple Calculated Osteoporosis Risk Estimation, Osteoporosis Self-Assessment Tool, Main Osteoporosis Risk Estimation Score. So just to give you an example, in musculoskeletal rehabilitation, how can you use these tools? So region-wise, I have segregated. So we'll just quickly go through these slides. In the cervicothoracic region and temporomandible joint, you have a diagnosis of cervical radiculopathy, which is a level 4 CPR. Predictor variables, cervical rotation, okay, towards the involved side, less than 60 degree. Positive upper limb tension test A, positive cervical distraction test, and positive swelling test. The clinical bottom line here, the presence of three or more predictor variables indicates a moderate shift in probability that a patient will test positive for cervical radiculopathy using needle electromyography. A methodological quality analysis is suggested before implementing this CPR as a component of the best available evidence. Prognostic example in cervical spinous, prediction of persistent whiplash associated disorders. It is also a level 4 CPR. Predicting short-term outcomes with cervical radiculopathy, level 4. Interventional cervical manipulation for mechanical neck pain, thoracic manipulation for mechanical neck pain, treatment of trigger points for chronic tension type headache, cervical traction for mechanical neck pain, occlusal splint for temporomandibular joint pain. All these are level 4 CPRs. Diagnostic, subacromial impingement syndrome and full thickness rotator cuff tear, level 4. Diagnosis of rotator cuff tear, level 3. Diagnosis of carpal tunnel syndrome, level 4. Classification of osteoarthritis of the hand, level 3. Prediction of persistent shoulder pain. This is a prognostic CPR for upper limb pain. It's again a level 3 CPR. Interventional mobilization with movement and exercise for lateral epicondylalgia, level 4. For the lumbar spine or lumbopelvic region, you have diagnosis of patients with lumbar spinal stenosis, level 3, diagnosis of pain originating from the sacroiliac joint, level 4, diagnosis of ankylosing spondylitis, level 4. Prognostic, prediction of recovery in patients with low back pain, level 3, Interventional, lumbar stabilization for low back pain, lumbar manipulation for acute low back pain, lumbar manipulation for acute low back pain, pro-lumbar mechanical tractions in patients with signs of nerve root compression, supine lumbar mechanical traction for low back pain, facet joint block in low back pain, response to exercise and ankylosing spondylitis level 4, classification of osteoarthritis of the hip level 3, diagnosis of hip osteoarthritis level 4, classification of osteoarthritis of the knee level 3, diagnosis of knee effusion level 4, diagnosis of medial collateral ligament level 3. Interventional, these are the interventional CPRs. Lumbar manipulation in patellofemoral pain syndrome, patellar tapping for patellofemoral pain syndrome, orthotics in patients with patellofemoral pain syndrome, prefabricated orthotics and modified activity for individuals with patellofemoral pain syndrome, hip mobilization in patients with knee osteoarthritis, manual therapy and exercise after inversion ankle sprain. So the future directions. CPRs present one branch of an evolving approach to clinical practice that conscientiously incorporates quantified research evidence into clinical decision making. Many clinical presentations encountered by musculoskeletal practitioners are probable ideal targets for such tools given the complexity of clinical judgments and the numerous assessments and management alternatives. It is widely hypothesized that the development of CPRs for musculoskeletal presentations has the potential to lead to substantial patient and system level gain, particularly those tools that are explicitly developed to address a currently unmet need identified by clinicians. So here we complete the CPRs. I hope you've understood the various types of CPRs and how do you decide the quality of a CPR and how do you derive a CPR. The various stages of the development of a CPR is also equally important. So that's it. So I'll just leave you with a case study. A 52-year-old right-handed female high school teacher presenting to physical therapy 3 weeks after insidious onset of left-sided neck pain, as well as shoulder and arm pain down to the first 3 digits. The past medical history non-contributory, aggravating factors cervical extension, left rotation, and left side bending. Relieving factors supine position, ibuprofen. NDA score is 34%. Fear avoidance belief questionnaire, work subscale 14. Fear avoidance belief questionnaire, physical activity subscale 8, and patient-specific functional scale 12. Physical examination, negative test, sharp Purser test, Hoffman's sign, vertebro-basilar artery insufficiency test, dermatomal, myotomal, and reflex testing were within normal limits. Positive test, Sperling's test, ULPTA, cervical distraction test, shoulder abduction sign. Posture, slight forward head posture with rounded shoulders and decreased upper thoracic kyphosis. Cervical range of motions are, as mentioned, extension 25 degree, flexion 55 degree, right side bending 40 degree, left side bending 30 degrees. Cervical active range of motion, right cervical rotation 80, left cervical rotation 50. Cervical flexion test 26 mmHg held for 8 seconds per pressure biofeedback unit. Passive intervertebral motion, left-sided mid and lower cervical hypermobility with reproduction of the patient's comparable symptoms during lower cervical assessment. So quickly, we'll just go through this. So clinical decision making. Now, based on this case scenario, how will you decide or how will you actually apply CPRs for this case? So the best thing is you can go for this Weiner et al. CPR. This is a diagnostic CPR, and this will tell you whether the patient has cervical radiculopathy. So in the current case, the patient meets all four predictor criteria, resulting in a large and conclusive shift in the post-test probability of the diagnosis of cervical radiculopathy. So since the patient has met all the four predictor variable, you can 100% be confident that the patient has cervical radiculopathy. Prognosis. The patient's likely prognosis can be predicted with the use of a CPR derived by Phelan et al. The patient meets three of the four predictor variables, thus producing a moderate shift in probability that a clinically meaningful change in outcomes will be achieved within 4 weeks. So this is the CPR. Interventions. Cervical traction. This patient has been classified into the centralization subgroup due to the reproduction of her upper extremity symptoms. So here she meets 4 of the 5 criteria identified by Rane et al., indicating a large and conclusive shift in probability that she will benefit from mechanical traction. Again, we use CPRs here. This is a CPR by Rane et al. Thoracic manipulation. This is a CPR to find out whether a patient will benefit with thoracic manipulation. Deep neck flexor strengthening. Pressure biofeedback testing has indicated a lack of deep neck flexor endurance. So currently, a prediction rule does not exist to identify individuals who may benefit from deep neck flexor training. But however, from research, it has been identified as an important component in the treatment of individuals with cervical radiculopathy. So all of the CPRs included in the clinical decision making for this case are level 4 in development, thus requiring careful consideration of multiple factors prior to incorporating them into the management of this patient. So all the CPRs you have currently is level 4 CPR. So you need to be very careful, use a clinical reasoning skill when you implement this CPR into your clinical practice. First, the methodological quality of each rule should be assessed to confirm it has limited bias. Second, the characteristics of the study sample should be analyzed to determine their resemblance to the patient in question. So the CPRs need to be applied in your particular patient population. That is also very important. Finally, the study statistical parameters should be considered to determine the magnitude and direction of probability shift and whether this shift surpasses the treatment threshold. So the 4 CPRs used in the study to help guide clinical decision making in this case possess quality scores of greater than 60%, indicating high or acceptable levels of quality. The subject's age and gender are similar to the population studied within the CPRs in question. So additionally, the patient meets the inclusion criterion and would not be excluded from any of the CPRs. The duration of the episode of neck pain, 3 weeks, suggests she may be slightly more acute than the typical subject in the derivation studies for these CPRs. However, related research indicates greater improvements with manual therapy in individuals who are acute. Thus, this would not be a reason to abandon the use of these CPRs in the clinical decision making. Location and behavior of symptoms are also very important. Determination for a favorable prognosis for this patient was established through the use of CPR by Cleland et al. The individual in this case met 3 of the 4 variables, identifying a moderate shift in probability that she will significantly improve within 4 weeks. Treatment based on the patient's status on 2 CPRs indicates the potential benefit of thoracic manipulation and cervical traction. The patient meets 4 variables on both CPRs, creating large and conclusive shifts in probability that she will benefit from these interventions. So in this case, we can be 100% sure that the patient is going to benefit from thoracic manipulation and cervical traction because they have met all the 4 variables on both the CPRs. So despite these findings, the clinician must remember that the confidence intervals in both instances were wide, with the lower end indicating a small shift in probability. For this reason, it is important that the decision to incorporate these interventions be confirmed from further research. So in this case, recent evidence has demonstrated the benefit of a multimodal treatment approach for patients with cervical radiculopathy. So here, along with the CPRs, you also need to consider the evidence-based literature also. So by incorporating clinical prediction rules in the management of this patient, the diagnosis, prognosis, and intervention plan were efficiently and effectively achieved. So I've just given you an example. How will you treat a patient with cervical radiculopathy using CPR? How will you diagnose a patient with cervical radiculopathy using CPR? And how will you establish a prognosis for a patient suffering with cervical radiculopathy? So these tools allow the clinician to define his or her clinical decision making and improve his or her level of confidence in these decisions. So the methodological quality was considered, as were the statistical parameters of the rules. Interventions with strong evidence were used in conjunction with the CPR findings to formulate a comprehensive plan of care for the patient. So despite the high quality of the current level 4 CPRs and the strength of the existing literature further confirming the CPR findings, the management of this patient will include frequent re-examination of impairments and functional level outcomes to determine the validity of the diagnosis, the effectiveness of the intervention, and the accuracy of the prognosis. So these are the references. So I hope you got a fair idea about what are CPRs. And in the end, I also gave you a case study to make you understand how can you implement CPRs for diagnostic, prognostic, and treatment purpose. That's all. Thank you.
Yes, thank you, sir, for the commendable and so informative talk. And I have actually one doubt. Okay, is there any checklist for the CPRs of like any questions based on that? Are there any questions for which we will say that yes, this is the level 1 or level 2 predictive rule for CPRs?
No, see, the levels you identified are based on the quality of the CPR. So you need to find the levels. So you need to find out, you need to search whether this has met all the 4 criteria. Like no, all the 4 stages in the development of CPR. So levels you decide based on the development stage of a CPR, whether it has undergone derivation, uh, a narrow validity, broad validity, and lastly, impact analysis. And depending on the quality, you decide whether the CPR can be implemented. So for every individual CPR, you'll have to search separately.
Okay.
And again, remember that CPRs are not available for all conditions. So whatever conditions are available, you can use it. And as I told you, for musculoskeletal rehab, currently we can go for diagnostic and prognostic CPRs, but not prescriptive CPRs.
Yes. So the talk. So we will end this session. On behalf of all Physio TV, I would like to thank you, sir, for enlightening with this commendable talk. I would also like to thank our principal, Dr. Apurva Shimbi, and our chairman, Dr. Parag Sancheti, sir, our chairperson of Sancheti Healthcare Academy, Mrs. Manisha Sangvi, ma'am, our technical team, and of course, our dear Physio TV viewers. Thank you all and have a great day. Thank you, sir.
Thank you, Barkha. It was a pleasure. Thank you.